Respiratory acidosis comprehensive overview. A. Description. Respiratory acidosis occurs when the total concentration of buffer base in the blood decreases due to an increased hydrogen ion concentration. This imbalance arises when carbon dioxide, CO2, a byproduct of metabolism, is not effectively exhaled. Excess CO2 combines with water in the blood to form carbonic acid, which dissociates to release hydrogen ions, leading to an acidotic state. The body's buffer systems, like bicarbonate, are overwhelmed by the accumulation of hydrogen ions. Clinical correlation. The acidotic state impairs cellular function, particularly in the nervous, cardiovascular, and respiratory systems. Symptoms like confusion, lethargy, and dysrhythmias can be traced to the effects of acidosis on neuronal activity, myocardial function, and electrolyte balance. B. Causes. Respiratory acidosis stems from factors that impair ventilation, obstruct the airway, or depress respiratory centers. These can be divided into pulmonary and non-pulmonary causes. 1. Pulmonary causes. Asthma. Spasms of bronchiolar smooth muscles caused by allergens or irritants result in restricted airflow and ineffective gas exchange. Atelectasis. Mucus plugs or anesthesia-induced alveolar collapse hinder oxygenation and CO2 elimination. Bronchitis, bronchiectasis. Inflammation or structural damage leads to airway obstruction, trapping CO2. Pneumonia. Mucus production and alveolar congestion prevent adequate CO2 exchange. Pulmonary edema. Fluid accumulation in alveoli reduces diffusion capacity. Pulmonary embolism. Vascular blockages compromise oxygenation, increase CO2 retention. Chronic obstructive pulmonary disease, COPD, and emphysema. Loss of alveolar elasticity reduces ventilation efficiency, leading to CO2 buildup. 2. Non-pulmonary causes. CNS depressants. Medications like sedatives, opioids, and anesthetics suppress the respiratory drive, leading to hypoventilation. Brain trauma. Increased intracranial pressure disrupts the respiratory center in the medulla. Hypoventilation. Reduced respiratory effort due to neurological or muscular conditions increases CO2 retention. Clinical correlation. Each condition impairs the respiratory system's ability to expel CO2 effectively, leading to acid-base derangements. For example, COPD-induced hypercapnia worsens acidosis, which in turn depresses central chemoreceptors, creating a vicious cycle. C. Assessment. Respiratory acidosis requires vigilant monitoring of the patient's clinical signs and laboratory parameters. 1. Neurological symptoms, mild to moderate, headache, dizziness, confusion, and lethargy due to CO2's vasodilatory and narcotic effects on the brain. Severe, coma in cases of profound acidosis. 2. Cardiovascular effects, hypotension due to peripheral vasodilation. Dysrhythmias caused by hyperkalemia as hydrogen ions shift into cells in exchange for potassium. 3. Neuromuscular symptoms, muscle weakness and reduced responsiveness, progressing to seizures in severe cases. 4. Respiratory findings, initial compensatory increase in respiratory rate, hyperventilation, followed by hypoventilation in cases where lung function deteriorates. Hypoxia exacerbates the clinical picture, especially if oxygen delivery to tissues is inadequate. Lab investigations. Arterial blood gas, ABG, decreased pH 7.35, elevated PaCO2 45 mmHg, and in chronic cases, compensatory bicarbonate 28 mmHg. Electrolytes, hyperkalemia due to acid-base compensation. D. Interventions. Management focuses on addressing the underlying cause, improving ventilation, and monitoring complications. 1. Immediate measures. Monitor for respiratory distress, hypoxia, and changes in consciousness. Administer oxygen as prescribed to correct hypoxemia. Avoid excessive oxygen in COPD patients to prevent suppressing their hypoxic drive. 2. Positioning. Semi-Fowler's position to enhance lung expansion and facilitate gas exchange. 3. Pulmonary hygiene. Encourage turning, coughing, and deep breathing to clear secretions and improve alveolar ventilation. Perform suctioning if necessary to remove airway obstructions. Avoid depressants. Avoid sedatives or opioids that further depress respiratory function. If used, consider reversal agents like naloxone. 5. Pharmacological support. Administer bronchodilators, e.g., albuterol, or anti-inflammatory agents, e.g., corticosteroids, for conditions like asthma and COPD. Diuretics for pulmonary edema to reduce fluid overload. Mechanical ventilation. Consider endotracheal intubation and mechanical ventilation in severe cases where CO2 levels exceed 50 mg or if acute respiratory distress persists despite initial measures. Clinical monitoring and rational approach. ABG monitoring. Regularly check blood gas results to evaluate treatment effectiveness and identify trends. Electrolyte management. Monitor potassium levels to address hyperkalemia-related dysrhythmias. Safety measures. Protect the patient from injury during periods of confusion or altered consciousness. Education. Teach patients with chronic respiratory conditions, e.g., COPD, about pulmonary hygiene, medication adherence, and avoiding triggers. Clinical correlation. Interventions aim to break the cycle of hypoventilation and hypercapnia. For example, improving ventilation via bronchodilators or mechanical support lowers CO2 levels, raising pH and alleviating neurological and cardiovascular symptoms. Key takeaways. Pathophysiology. CO2 retention leads to increased hydrogen ions and a reduced pH. Causes: obstructive or restrictive respiratory conditions, CNS depression, or trauma. Management. Focus on ventilatory support, oxygenation, and addressing the underlying cause. Complications. If left untreated, respiratory acidosis can progress to multisystem failure due to hypoxia and severe acidemia.